Good afternoon, everyone.
Good afternoon. Am I audible? I'm Dr. Naveen.
Yes, sir. Yes, sir. You are audible, sir.
Please make I want to share some PPT. Just
Yes,
make
sir.
me a co-host so that I
Sure.
can.
Yeah, make sir already. Done,
Sure.
sir.
Done, na? Okay, let me
Done.
see. Okay, fine. Yeah. Thank you.
Thank you.
Let me know when to start. Who will come? Who will be somebody will come and speak first.
Yes, sir.
No.
We will host from
Okay, then I
our
will
end.
wait. No problem.
And yeah, sir. Yeah, we will start just for checking the mic.
Sure. Thank you.
Yes. Thank you, sir. Thank you.
I call to Lata, ma'am. Hey, yes. Prachit.
Dr. Girish?
ಎಸ್ ಮೇಡಮ್ ಹೇಳಿ ಮೇಡಮ್ ರಜಿ ಮೇಡಮ್
ಪ್ರೋಗ್ರಾಮ್ ಎಷ್ಟೊತ್ತಿಗೆ ಶುರುವಾಗುತ್ತೆ ಗೊತ್ತಾಗ
ಈಗ 1 ನಿಮಿಷಕ್ಕೆ ಶುರುವಾಗಬೇಕು.
ಶುರುವಾಗುತ್ತೆ ಮ್ಯಾಮ್. ಜಸ್ಟ್ ಅ ಮಿನಿಟ್ ಮ್ಯಾಮ್.
Okay.
Prachit is there.
ಥ್ಯಾಂಕ್ ಯು ಮ್ಯಾಮ್. ಥ್ಯಾಂಕ್ ಯು.
Yeah, thank you.
So, very good afternoon to one and all. So, we welcome you all to this Mental Health Dialogue 8 that is being carried out under the aegis of National Mental Health Survey 2, a project by Ministry of Health and Family Welfare, Government of India, which is being carried out in all states and union territories of our country, with NIMANS being the implementing institute. So the topic for today is mental health among institutionalized persons, that is, those residing in orphanages or prisons, healthcare institutions, juvenile detention centers. So this is an overlooked issue, and reports have suggested that the prevalence of mental morbidity among such individuals could be higher than the general population due to various stressors and risk factors. So it's imperative that appropriate measures, not just clinical measures, but public health measures are implemented to address this issue. And we are very happy to have esteemed resource persons who have joined us, who have consented to share their expertise with us. So we look forward to a very fruitful learning experience. Over to you, Dr. Akash and Dr. Sanu.
Thank you, Prachit sir, for that. We welcome you on board, everyone, for this MHD session. My name is Sanu Kumar Singh. I'm program coordinator for NMHS2 and one of the MHD moderator for this session as well. Before we begin today's mental health dialogue, we would like to briefly overview about National Mental Health Survey. NMHS 1 was undertaken during 2015 and 16 in 12 states, covered nearly 2/3 of the population of the country. Following up with the learnings from NMHS 1, NMHS 2 is planned to estimate the burden of mental health problems in a nationally representative population, understand healthcare seeking pattern and family burden of illness, document the current status of mental health care services and mental health system assessment, that is MHSA, including characterizing vulnerability to mental illness across all 36 states and UTs of India. Now, I would like to request Dr. Akash Anand to give an overview of today's session. Dr. Akash, over to you.
Thank you, Mr. Sanuji. As the conversation around mental health continues to evolve, the mental health dialogue has become an increasingly important space for meaningful exchange among policymakers, mental health professionals, and other key stakeholders. We are excited to welcome you all to this 8th edition of Mental Health Dialogue, where we will focus on mental health of institutionalized individuals. The first session will dive into understanding the unique challenges faced by this group, followed by a panel discussion on mapping mental health in an institutional setting. Before we begin with today's first session, we would like to thank you for your enthusiastic response and interest from a diverse group of stakeholders for today's theme. The future edition of Mental Health Dialogues will continue to explore specific subcategories within institutionalized population.
Thank you, Dr. Akash, for that. With that in mind, we would like to invite our first speaker for the day, Dr. Naveen Kumar C. Dr. Naveen is Professor of Psychiatry and Head of Community Psychiatry Unit at NIMHANS, Bangalore, and Office in charge of the Center of Excellence in Climate Change and Mental Health under India's National Program for Climate Change and Human Health, Ministry of Health and Family Welfare. He has led statewide capacity building to scale up the district mental health program, helped craft Karnataka's Mental Health Action Plan and Mental Health Care Act 2017 regulations, and coordinated both the national level helpline for psychosocial distress during COVID-19 and the telemental health initiative. Uh, uh, Dr. Naveen sir, over to you. You can share your slide if anything is there from
Yeah,
you.
yeah, yeah.
Thank you.
Thank you. Thank you very much. And thank the organizers for having us in this program. So although the program is about institutionalized persons, as Prachet was saying, it's a very huge population. And I should confess that I don't have the competence to talk about all institutionalized persons. So I've just restricted myself to one of the biggest institutions among the institutionalized, that is a prison. So because I have some experience along with Rajni and Suresh and other people to have worked in some prison settings. So what I will be doing in the next 5-10 minutes is to talk about prison mental health and what we have done, with regards to that. So I'll be sharing the presentation. Is that audio? Is that visible, Mr. Sanu?
Yes, Naveen.
Yeah, thank you. So when we talk about correctional settings, as somebody was pointing out, there are about 11 million people around the world, and the prevalence is very, very high when compared to that of general population. At the same time, India, there are very, very few studies. So the key issues are, in correctional settings, I think my intuition says it's the same thing in all institutionalized settings as well. But, when we should talk about high prevalence of mental health and substance use conditions, very few psychiatrists and other mental health professionals to take care of them. And there are also the mental health issues of the staff. These are the three core issues. When we look at studies, I'd like to talk about this Bangalore prison mental health study. Rajni is here, who is also one of the investigators at that time. So what we had done, it was published in 2010. It's all there in the public domain. It was kind of a landmark initiative because the recommendations given in this study have been actually in toto taken up for the as a minimum standard for mental health care in prisons under the new Mental Health Care Act. It is there. The minimum standards have been notified, which exactly are the same as the recommendations of this particular study. So what we did was we actually surveyed the entire population of Bangalore prison. At that time, it had a population of about over 5,000. So mini plus interview schedule was used, and almost about 79.6, that's about 80%, they had either mental illness or substance use. So 27% of them had one or the other mental health disorder, excluding substance use. So depression and anxiety was the most common after the substance use disorders. 2 out of 100 had attempted suicide, and 7 out of 100 had deliberately caused self-injuries. When you look at other studies in India, so there are actually some studies. The Goel et al. Said that about 24%. Kumar's study, talked about 59%. One more talked about 70%, and other person talked about 83-84% of inmates having psychiatric disorders. So a very wide variation, but nevertheless, it's very clear that prevalence the burden is very, very high, and there needs to be some system. So when we look at the existing systems, as far as my knowledge goes, I may be again not very this thing, but practically none exists. Very few and far. Things are better in recent years. I stand corrected. If there are any systematic, if there are any systems to take care of these. DMHPs are now getting involved, wide variability in accessible services. And I thought that NMHS 2 could be one of the avenues to include prison setting for mapping the resources. So when you, at that time, for about 5,000 inmates, there was only one psychiatrist. The same thing in Maharashtra, one psychiatrist was there for about 43,000 patients, inmates. And a lot of vacancies were, lying vacant. So that is the issue with regards to the systems when we talk about prison mental health. The NIMHANS has been involved in various initiatives related to prison mental health. I'll just talk about these things. This is about 12 years old. At that time in Bangalore prison, there was a telepsychiatric consultation, and this small study showed the utility of that telemedicine services. because it actually saved a lot of time and effort for the patients to come to a tertiary care institution. A lot of convenience was there, but somehow that system did not get succeeded. The other important issue that I'd like to talk about is the collaboration with Bihar Prison Department. For 2 or 3 continuous years, we have been involved in training medical officers working in Bihar prisons. We had designed a year-long hand-holding program with the digital modules and training of the medical officers. Though the specific emphasis was that for them to recognize symptoms and signs of mental illness and managing high-risk groups, where the manipulative patient, the violent patients, this particular small piece of research talked about the outcome evaluation, where you could see at the end of 6 months, the translational quotient, that is the amount of skills that they have got, was 63 on 100, which actually increased to 76 at the end of 1 year. So it showed that there was a continuous increase, and the components of the translational quotient also had increased. You could see EPS. EPS is elicitation of psychiatric symptoms. That skill. The CR is the clinical reasoning of caseness for psychiatric diagnosis. The ADM is appropriate decision regarding choosing the psychiatric medication. BC, whether the components of basic counseling. The TMT is the time management for psychiatric evaluation, the primary care level, as well as overall clinical skills. All these things showed increase, at the end of 1 year. And this is the report of how many cases were diagnosed to have psychiatric disorders in Bihar prisons at that time. Bihar prisons mean not all of the Bihar prisons, where are trained medical officers situated. The total consultations reported was about 33,500, out of which almost 3,000 were picked up as having psychiatric disorders. That is about 9% of them, were having psychiatric disorders. So, like, for example, all sorts of diagnosis in terms of tobacco use, alcohol use, anxiety disorders, depressive disorders, somatization, psychosis, and suicide attempts were seen. And antidepressants, benzodiazepines, anti-craving agents, bupropion, and antipsychotics drugs also, a number of cases were referred also. And here you could see the quartile-wise comparison. Every quarter, the number of cases seen, kept on increasing, and this is the trend. So this, what I wanted to convey was that if there is a long-term mentoring of non-specialist doctors, a lot can be achieved. And one more study that we did in NIMHANS itself, we studied the long-term clinical outcome of patients who were charged with, at that time, it was IPC 302, for homicide. The long-term outcome was about, for 15 years, we were able to study the outcome. All sorts of major psychiatric disorders we had got, that is psychotic disorder, mood disorder, alcohol use. And we were able to get information up to 15 years. And you could see the average of the average CGI score at the end of 15 years was 1. That is normal or not at all ill at the end of 15 years. That was kind of, reassuring the conclusion in the end where clinical outcomes were promising if there is accessibility to seamless services, whether it is a district level hospital or a tertiary care hospital. If basic services are available, then we could ensure some good clinical outcomes for these institutionalized persons. That is the message I want to give. Now, coming to the mental health issues in correctional setting staff, they reported extremely high level of stress. You could see the percentages. There were many issues like manipulative behaviors from the prisoners, malingering, and lack of securities were some of the issues that were reported by staff. So this also shows that the staff working in such settings also require mental health services. The similar initiative with Bihar prisons is about 300 jailers and warders. We have been hand-holding them, with digitally driven training. And this was about 6 months back. And even now, they are actually counseling patients. They are screening persons with, serious mental health issues, and they're doing the referral. We don't have the systematic data to report, but anecdotally, I could say that I had a recent meeting with the Bihar prison officials, the medical department of the prison department officials, and they actually showed me every month they are sending statistics to the state level, elucidating how many counseling sessions they have done and so on and so forth. And we are in constant touch with these staff to, equip them with more and more skills. Now, there are some policy level issues also, like, for example, Section 103 of the Mental Health Care Act talks about prisoners and mental illness and what are the provisions related to that. This is the minimum standards for mental health care in prison that I was talking about. Actually, what is prescribed is 1 doctor for every 500 patients, 2 nurses for every 500 prisoners, and 4 counselors for every 500 prisoners. I know we are. This is very. It looks very utopian and ideal, but this is what is the prescribed standard, and some sort of ideal is there. It's always for us to see how far we can. So that is this is another slide related to the minimum standard. We have also come up with the resource material for dealing with mental health issues inside prison, both for the inmates as well as the prison staff. So I'd like to end just by stating that prison is a very large institutional setting. Mental health morbidities are very high. There are practically no systems that are existent, and some initiatives from NIMHANS to mitigate these kind of challenges. So with this, I'd like to end, and thanks for having given us this opportunity. Thank you very much. Over to you, Mr. Sanu.
Thank you, sir, for that very insightful presentation on prison mental health. It was really interesting to look at the real-time data from across studies as well as important initiatives taken by NIMHANS. You also highlighted the importance of mental health professionals in this setting. So thank you for that. With that, I would like to call upon Dr. Prachit R, Associate Professor of Epidemiology NIMHANS, to welcome and introduce the panelists for next session.
Yeah, thanks once again, Naveen sir, for giving your insights on that very crucial topic, very important topic on mental health among persons in prisons, and for highlighting your work. So if there are any questions, you could please put them in the chat box. So we'll try to take them maybe after the panel discussion. So I believe Rajni ma'am has another meeting at 4 p.m. So I'll very quickly introduce Dr. Rajni to the audience. So Dr. Rajni is the Deputy Director of Mental Health in the government of Karnataka. So she's also the medical advisor to the Karnataka State Mental Health Authority. With an MBBS and a diploma in psychological medicine, Dr. Rajni has worked on expanding the district mental health program statewide, pioneered the NIMHANS Eco-Tele mentoring, and co-developed the eManas portal for Mental Health Care Act 2017 compliance. As the co-investigator in the project Mental Health and Substance Use Assessment and Approach in Prisons conducted by NIMHANS in collaboration with the Prison Department, she has co-edited the book Minds Imprisoned with NIMHANS Doctors. A recipient of the 2023 Keshav Desiraju Memorial Award, Dr. Rajni brings deep clinical expertise and visionary leadership to our dialogue. So, ma'am, we are very thankful that you could accept our invite and join us for this mental health dialogue program. So, ma'am, first of all, I would request you to kindly give your insights on the topic and throw some light on the work that you have done with respect to mental health among imprisoned persons.
Yeah, thank you very much for the entire team for giving us an opportunity, and thanks that I am with other esteemed panelists, like I can see Malayappan sir and many others. So basically it is very, that was my first posting, so I'm always happy to talk about prison work, what we did. Basically, what happened was I was an in-house psychiatrist, single psychiatrist. More than 5,000 prisoners were there in Central Jail, Bangalore, which was the biggest jail in Karnataka. And then we used to tell our, DGIG that, sir, a lot of substance abuse and mental health problems are there, and we need more mental health professionals to cater to imprisoned people. And anybody and everybody, they come with a lot of depression, anxiety, substance abuse. So then Mr. S.T. Ramesh, very eminent IPS officer, So he told us that you people are telling that there is a lot of substance abuse and mental health issues, and why don't we start a study? So then only we approached Karnataka State Legal Services Authority, who funded the project. And of course, Dr. Naveen has elaborated what all we did. It was a 1.5-year study where we hired just 3 social workers. And then I was the in-house psychiatrist. On a daily basis, I used to see patients there. And I was a single psychiatrist, and at any point of time, more than 500 psychiatric patients were there. Many were very violent, patients, persons with mental illness. One person I still vividly remember, the moment somebody doesn't allow him to go out, he would break at least 15 to 18 glasses at a time. So, and one person would just break, the STD booths which were kept. So these were the cases which we were handling when we were in Central Jail, Bangalore. And then, of course, the study, this is one of the biggest study in Karnataka, India, and probably in Asia. Even today, I think that is the biggest study, more than 5,200 prisoners. And one more unique thing in our study was anonymous urine screening of 1,200 prisoners. And then the book anyway is there in the website. If you put Niman's Prison Study, you can go through the 2 books. And what I would suggest is, even today, if you see Karnataka, the mental health establishments per se are not there in the jails. The barracks are converted and designated barracks. For example, some 10 barracks are converted into hospital, and that is named as hospital, and it is not exactly as per the norms of mental health establishment. So to improve, of course, now after the recommendations given by our team, things have improved to a larger extent. The number of social workers have increased, number of psychiatrists have increased to from 1 to 3 in Bangalore jail, but still long way to go. As I said, the inpatient care and then the drug testing, all those things are not there, which have to be put in place.
So thank you, ma'am. Thank you for sharing your inputs as well as giving us some points for improvement as far as mental health among imprisoned persons is concerned. So, ma'am, how can we overall strengthen the infrastructure for mental health services among such individuals? If you could elaborate on
Basically,
that.
there is a mandate as per Mental Health Care Act also that at least in few prisons, the mental health establishment has to happen. So if you take example of Karnataka, we are planning to now at least establish mental health establishments in 4 regional. We have Bangalore division, Mysore division, Belgaum, and Gulbarga division. So we are kind of discussing and moving files to establish at least mental health establishments in 4 prisons, 1 per region. And also multiple circulars we have sent to all the medical colleges and district hospital. As Naveen was telling, that if the facilities are available locally at the district hospital level and the medical college level, they need not come to Bangalore Central Jail, which is happening from many decades. So they just refer cases from entire Karnataka to Bangalore Jail, and then they will be referred to Niman's. So we have also sent, instructions to all the district hospitals and medical colleges that they have to designate 5 to 10 beds for the prisoners, especially person with mental illness, for males, females, and also the other gender if in need. So these are the, steps taken in Karnataka. And I'm sure Bangalore Central Jail, they have already taken registration as mental health establishment. So it is better than other jails. And we have outpatient services. We have 3 psychiatrists, around 8 social workers, and 1 psychologist at Bangalore Jail. Mysore Jail also, we have a psychiatrist and a few social workers. All the central prisons have social workers now. Around 20 social workers are there in put together some 8 central prisons. So those social workers are also trained for screening and brief counseling of the needy prisoners. And because of the circulars, now most of the prisoners are Of course, few are referred to Bangalore and then to demands and other things. So even in demands, up to 60 beds are there now, the Dharwad Institute of Mental Health Sciences. And also all the medical colleges have started treating, and the district hospitals, whenever a prisoner or any institution for that matter. For other institutional care, for example, child care institutions are there, old age homes are there, Nirashrita Parihara Kendras are there, where they call, previously they were called
Homeless
beggars
persons.
colonies, but now it is Nirashrit Parihara Kendras.
Nirashrit.
Around 14 centers are there in the state. Our district mental health program teams, they go to those kendras also. And they also go to women homes, where many people, up to 30% of them have mental health issues also. So the DMHP teams, they visit prisons. They also visit women homes. They visit old age homes. They visit childcare institutions. So all these are happening. And even a kind of institutionalization, if I have to say, but there is no, they are not locked up. Like many dargahs, temples, churches, there also people are kind of abandoned. They are not locked up in a space, but it is kind of they are abandoned in those places. For that also, we have kind of expanded this Dawa Dua program across the state to take care of those people. First in its kind in India, I think probably inside the Dargah premises in Chikbalapur, we launched a counseling and treatment center last October. But from past 8 years, the services are going on. This was expanded to many churches, dargahs, and temples last year. So these are all the few, improvements that we are doing incrementally every year.
So it's very nice to know, ma'am, about the initiatives and the efforts that have been put in by the Department of Health and Family Welfare Government of Karnataka. Thank you very much for sharing those insights. It was very comprehensive and useful for us, ma'am. Thank you, ma'am, for joining us.
Thank you.
So let's move on. I would like to introduce the other distinguished panelists here. So we have Dr. M. Malayappan, sir. So he's done MBBS and MD in psychiatry. He's currently the director of the Institute of Mental Health, Kilpauk, Chennai, and a professor of psychiatry at Madras Medical College, and the CEO of the Tamil Nadu State Mental Health Authority, as well as the state nodal officer for the district mental health program. With nearly 3 decades of experience in teaching and leadership, and plus shaping legal psychiatry scholarship, championing human rights, and drafting the state mental health policy, he brings unparalleled expertise to our panel. So we welcome you, sir.
Good afternoon.
Good afternoon, sir. Thank you for joining us. So the next panelist is Dr. Preeti Arun, who is currently serving as a professor of psychiatry at Government Medical College Hospital, Chandigarh. She has nearly 4 decades of clinical experience in child psychiatry, autism, and disability. She has authored over 120 publications and 11 book chapters. She has co-edited the textbook of community psychiatry in India and is a recipient of multiple national and international awards. We welcome you, ma'am.
Yeah, thank you so much. Thank you so much for having me here for this panel discussion.
Thank you, ma'am. And then we have Dr. Samrat Singh Bhandari, who is a professor of psychiatry at Sikkim Manipal Institute of Medical Sciences, Gangtok, and has been an undergraduate teacher since 2012 and a postgraduate mentor since 2018. After earning his MBBS from Assam Medical College and MD in psychiatry from Guwahati Medical College, he completed a fellowship in epidemiology at the University of Florida. Dr. Bhandari's work spans the epidemiology of substance use, schizophrenia and affective disorders, school and geriatric mental health, and community-based research to expand service access. So, sir, we are extremely happy to have you here as our panelist. Welcome, sir. So now I would request my colleague, Dr. Lata K, who is an associate professor in the Department of Mental Health Education, NIMHANS, and is an integral part of the National Mental Health Survey as the co-PI of NMHS2 Karnataka site, to kindly take this forward. Over to you, Dr. Lata.
Thank you, Prachit. So at the outset, I would like to thank all the esteemed speakers and panelists for joining us today to discuss on this integral aspect of mental health care for institutionalized individuals. So we all know that mental health care for these institutionalized individuals mainly aims to provide support and treatment for these individuals and who are often in a secure and structured environment. So I think already Dr. Naveen sir and Rajini ma'am have given an overview about especially prison settings, the individuals who are placed in prison settings and what kind of concerns they are actually going through. So just to highlight a few, like some of them are mainly related to the safety, the consent or confidentiality, privacy, then also about the transition and reintegration of such individuals back into the community. So let us now move forward with a panel discussion. And I would like to ask the first question to Dr. Preeti Arun. Madam, how can we address the gap in having this trained mental health professionals within institutional settings? Because we already heard from the previous speakers also that a lot of these vacancies are unfilled and also we are facing a lot of this staff shortage.
Yeah, thank you so much for this very important question, because this will always remain a major issue, that how do we fill up this gap? But I think what needs to be done is to follow up the NIMHANS model, the work that has been done in Bihar, basically to educate more and more people who are already working there in mental health issues and in delivering of some basic mental health intervention. If they identify and if it can be linked up through telepsychiatry or something, that would that itself would bring about a huge change, and at least the people would get proper intervention and services. So training of more and more people who are already working in prisons. That's what
Thank
I
you,
would say.
ma'am. Thank you very much. So already I think Dr. Naveen sir also put it about the online programs and modules which are already initiated, and also there is a lot of scope for subsequent capacity building. Thank you very much, ma'am. So now I would like to proceed with Dr. Samrat. What are the most prevalent mental health challenges faced by institutionalized individuals, particularly in correctional facilities and psychiatric institutions that you have come across?
Am I audible, ma'am?
Yeah, yes.
Yeah. So challenges as a psychiatrist, what I have faced. Yeah, okay, ma'am. So as a psychiatrist, I feel like we are here in Sikkim unable to maintain the continuity of care. And once the patient or once the inmate is out of the prison,
Unable to hear you, Dr. Samrat.
oh, sorry. Yeah. So it's difficult to maintain the continuity of care. That is one that I have felt. Second thing, though all the prisoners or inmates, once they are inside the prison, though there is not a structured screening for psychiatric illness, but we do visit every week. The psychologist visit and the psychiatrist visit once a month. So usually we see all the patients. So, but what happens, like it's difficult for us to, for what I experience is it's difficult for me to make a diagnosis sometimes. For example, as Sir has already told in his presentation, number of antisocial personality disorder, psychopaths there. So they can malinger also, and we don't have a record to establish the past history. And also, there is no access to family. The state also cannot do not have the logistic to ask or bring the family member or pay for their travel expenses, or to keep them overnight so that a detailed history can be taken. So that is what I faced the challenge there here in Sikkim. So these are the few of the challenges that I have faced, ma'am. Establishing a diagnosis, then maintaining the continuity of care. And thirdly, also in Sikkim before 2018, we had this OST, oral substitution therapy, but it was stopped because of lack of manpower. So the number of staff there were unable to monitor. Like patient used to, or the prisoners used to take the tablets, opioid therapy replacement tablets, and they used to keep it in their mouth, and later on they used to distribute it among the other prisoners. So it was very difficult to monitor them because of lack of manpower. So these are few of the challenges that I have faced here in Sikkim.
Thank you very much, Dr. Samrat, for bringing in those very, very crucial points or challenges which you have actually come across. Majorly the continuum of care, and also the challenges in coming across a diagnosis without having any facility for actually having an interaction or getting the detailed history from the family, no availability of records, and also the acute shortage of the human resources or mental health professionals to provide these supports. So I think the way forward is mainly about the capacity building, and also to looking at various comprehensive strategies so that like how we can strengthen the screening and also the inpatient services within these institutionalized settings. Thank you very much. So I would now like to ask the question to Dr. Malayappan sir. Sir, with the district mental health program implemented in all 38 districts of Tamil Nadu, we have models like these which are being successful and which are providing continuum of care post discharge. So could you explain on this?
In relation to correctional institutions, prison settings, you mean?
Yes, sir. Yes.
Yeah. Our DMHP psychiatrist, we have 2 psychiatrists in each district. In addition to that, we have government medical colleges where there are 4 to 5 psychiatrists in each district. So apart from DMHP psychiatrists, government medical college psychiatrists also make visits to prison. Each prison in all the districts of Tamil Nadu are visited by psychiatrists once or twice a month. So there is a regular follow-up of the patients who are previously admitted in a psychiatric hospital and then discharged the prison. So every month, once in 15 days or once in a month, they are seen by a psychiatrist, and a review of the psychiatric patients are conducted, and if necessary, modifications in treatment are made, counseling is given, and if necessary, patients are referred back to hospital if admission is required. So follow-up care is reasonably good if the mental health services in the state are good. More number of government medical colleges, more number of DMHP psychiatrists, more number of visits to correctional institutions. The number of visits, if it is more, then the continuum of care will be better. So by increasing the basic mental health services of the state, we can assure that the continuum of care in correctional institutions can be ensured. Yes, madam.
Thank you, sir. Thank you very much. So I would like to highlight some of the important points which you have stressed, mainly about increasing the number of visits and also stressing on the services, including the follow-up services, and also the number of staff through DMHP, mental health professionals through DMHP, so that we can ensure the continuum of care for these individual institutionalized persons. Thank you very much. Now I would like to request Dr. Prachet to take with the next round of questions with the panelists. Over to you,
Dr.
Prachet.
Lata. Thank you, Dr. Lata. So my next question is to Dr. Preeti Arun, ma'am. So this is more specific to Chandigarh. So with the low occupancy rates in halfway homes and the lack of dedicated mental health institutions, what strategies can be implemented to improve rehabilitation services for persons in institutions, ma'am?
So it had 3 aspects of the question. Thank you so much for asking this. One is about low occupancy of halfway home. So yes, we do have a halfway home, and occupancy is about 50%, not more. So we have 10-bedded halfway home, and so then second is about not having mental health institute. We do have a mental health institute in Chandigarh. It is 40-bedded, functioning fully, with all the rehabilitation related activities being conducted there. We have a disability assessment and rehabilitation triage program in our city run by our department. And there we are doing social skills and neurocognitive rehabilitation and vocational rehabilitation. We are doing a lot of work in terms of rehabilitation of persons with mental illness. Now, when coming to the institutionalized persons, if they require admission, then they do get admitted in our psychiatry ward. For long-term stay, because when you are having a prisoner in your ward, then you do need the security guards along with that. So that is done only for the period necessary for treatment. After that, they are sent back to the prison. And the rehabilitation aspect is not possible for institutionalized person in our institute. Then coming to the aspect of improving the rehabilitation services for institutionalized individuals. In Chandigarh, we do have a psychiatric social worker working in our prison, Burrell Jail. We do have one psychiatric social worker who had passed out MPhil psychiatric social work from our department. So I would say that, I was listening to the previous speakers, and in Chandigarh, Burrell Jail, the visit to the prison by psychiatrist is made once a week. Alternate week, it is by health department psychiatrist and medical education and research department psychiatrist. So the visit is once a week to the prison. Yeah, thank you so much for asking.
Thank you, ma'am. Thank you, ma'am, for those valuable points. So you spoke about the rehabilitation services that are delivered to institutionalized persons in Chandigarh, and the psychiatric social workers who are stationed in these prisons. And of course, there are once weekly psychiatrist visits, both from the government sector and the private sector as well. So from the government sector, so which would ensure that long-term care is provided to such individuals. Thank you, ma'am, for your valuable inputs. So my next question is to Dr. Samrat. So, Samrat sir, as a psychiatrist, how often do relapses occur, and what are the major factors contributing to these cycles among institutionalized persons from your experience?
Yeah. From my personal experience, and I can say that relapse is more frequent among the under trial prisoners, and sometimes because of uncertainty. And say, for example, after long duration of trial, and ultimately the person is convicted. So, like they go back to substance within the prison. And second thing, I feel like once a prisoner is out of the prison, as I told, there is no continuity of care. The person doesn't go to access the healthcare services. Also, maybe because of self-stigma and discrimination, unable to integrate with the society in a healthy way. So, because of unemployment, etc., they again, they start abusing the drug. And here in Sikkim, what they do is like the drugs they buy, half of the drug they sell it to others. In this way, they consume also, and they generate some money for themselves. So this cycle keeps on going because of unable to integrate with the society in a healthy way, unable to get employment, unable to get acceptance by family members also. So relapse is very frequent. Then I also feel like within the prison, like if a person has started taking treatment and he's abstinent, but because of substance abuse within the prison, they again start taking that. It normalizes the thing for them. I mean, because of cue-induced craving, others, etc., they start again, they relapse again. So these are the things that I have found in my personal experience.
Thank you, Dr. Samrat, for sharing your experience as a psychiatrist regarding the factors that contribute to relapse. Mainly, you spoke about substance use, stigma or denial, and also the role of family, which may prevent relapse. So, my next question is to Dr. Malayappan, sir. Sir, how can we ensure ethical care in mental health institutions, that is, upholding the dignity, preventing abuse, and avoiding involuntary treatment, while maintaining high standards of care to institutionalized persons?
For all institutionalized persons, you mean?
Yes, sir.
Mental health institutions in general.
In general, sir. In general, to the persons in institutions.
Okay. Mental health institutions now can be broadly classified into two groups. One is state-run large mental hospitals, maybe each 700 to 1,000, 1,500 bedded mental hospitals, fully run by the state government. The other type of mental health institutions are small, 50 to 100 bedded, NGO-run, partly funded by government, and partly run by private organizations, NGOs, even for-profit, not-profit organizations. We have large state-run institutions and small NGO-run, partly funded by government institutions. As far as I am concerned, there are no much difference between these two, large state-run and a small NGO-run mental health institutions. There is no major difference in the standard of care or the quality of life or the rights of the patients are concerned. There is no much difference between the two. It actually boils down to the funding. How much amount is being spent for the mental health care, the number of psychiatrists, the number of nurses, the number of psychiatric social workers, the number of clinical psychologists, the number of attenders, the number of all the staff, including pharmacists, physiotherapists. So the manpower, human resources involved in the institutions corresponding to the number of inmates, their attitude and training of the staff, and the building in which they live, the aeration, the ventilation, water supply, quality of food, hygiene, the cleanliness of the environment, privacy in taking bath, privacy in toilets, space, building, human resources, attitude of the staff. All these things matters in providing the basic needs of the long stay or intermediate stay inmate of a mental health institution. So all these things can be ensured only when there is an adequate funding and utilization of the funding. So that will be the major thing involved in improving the standard of care in mental health institutions in India, in my view. And clothes, for example, clothes, toiletries, soap, toothpaste, brush, napkins, sanitary napkins for women inmates. All these things matters in improving the quality of life. When there is a qualified psychiatrist who is reasonably having a reasonable attitude, then the medical treatment is reasonably assured. That will not be a problem. Apart from that, the basic necessities of life. The important thing is recreation, entertainment, how they spend time in their leisure time, what are the feasibilities for listening to music, for seeing television, for going for a picture, going out of the institution for a picnic. All these things matters. Recreation therapists, occupational therapists, skills training, all these things has to be in a comprehensive way in a mental health institution, whether it is a large state-run institution or a small NGO run government, partly government funded institution. If these things are assured, then the standard of care, the quality of life, rights of the individuals, all can be ensured. So it ultimately boils down to funding, utilization of the funding, human resources, attitude of the human resources, infrastructure, and basic necessities. If that are ensured, once the person is improved, naturally the social workers, psychologists, and the doctors, psychiatrists will be very much eager to send them back to the society, reunite them with the family, or send them back to work and live independently. So ultimately, it comes down to the infrastructure, money, and human resources, in my opinion. Thank you.
Thank you, sir, for speaking about those measures to uphold the standard of care in mental health institutions. So it's not just the human resources, they have to be trained. They need to have the attitude or mindset. A good environment needs to be there. Scope for recreation needs to be there. Funding and appropriate optimum utilization of funding is of paramount importance. So thank you very much for those points, sir. So we have a few questions in the chat box. So we'd be grateful if one of the panelists can please pitch in and take these. So the first question I'm just reading out. In the correctional home setting, do all the psychiatric evaluation and counseling sessions are conducted under audio? So here the question is more on the balance between safety of the psychiatrist and delivering a treatment.
I can take it up, Prachit.
Yes, sir. Please, Naveen.
Yeah. I don't think there is any audio or video recording if for consultations inside prisons. Outside, how it happens, inside also the same thing happens. And as regards confidentiality and safety, the risk is the same as for other patients, like other non-prison patients. The only issue is very specially designated prisoners. With them, there may be some issues. But in the West, there are separate segregated systems to deal with such high-end criminals and psychopaths. In our country, the system is not yet developed to such an extent. So, but the confidentiality and safety will be the same. I don't think there is any major difference. And of course, Section 103, I think, authorizes if I think there is some clause which states that if the mental health review board or some other authority, I am not able to recall, if that is there, that is enough authority for persons to be treated. I'll just get back on that. You give me a couple of minutes. That's my response.
Sure. Thank you very much for the response, sir. So we have another question here by Sahana Nag. So in juvenile justice system, so what special care is available for neurodivergent, for children, basically, for neurodivergent children?
So what I would like to
Yes,
comment on this question is that in all juvenile places, there are psychologists, social worker, and special educators available. And they do take care of all these people. And I mean, because in our OPD, we do get children from institutes where children are residing, institutes for care, not only for care of protection, for care and protection, not for like juvenile justice home. And they do have all these facilities. And whenever they are lacking in training and all, we do conduct these trainings or we do handholding.
Reorient them, handhold them. Yes. Thank you very much for the points. There's another question by Chaitra S. How do you think institutionalization affects a person's identity and self-worth over time?
Okay, I think I can take it up,
yes,
but in a very general sense, because I have not done any research on this particular area. I think it is that comes in the realm of psychiatric social work. I think there are a couple of theses also that have come from NIMHANS. Of course, talking from a commonsensical point of view, it depends on the experience, long-term experience of the individual who has been institutionalized. We have come across people who have found out their sense of identity within the institutions. I'll take the example of our own institution. Many inmates are residing there for a long time. And I mean, you just have a casual talk with them, you understand that they're okay. I mean, they have resolved to the fact that apart from this institution, there's nothing else that they could look forward to. But overall speaking, I think it also depends on what is the premorbid personality, what was their functionality. For example, if an engineer becomes institutionalized, obviously the institutionalization will have a definite a negative impact on the sense of identity. So likewise, there's no hard and there's no black and white responses to that. There are many shades of gray. That's what I feel. Thank you.
Thank you very much, sir. So we have one more question by Sherin James, who is the program coordinator at NMHS2. What role do staff's attitude play in mental health? So Malayapan sir, if you could please throw some light on this, or any of the panelists or speakers, if you could please.
I was about to log off now. I think
Oh,
quickly
yes, ma'am.
I'll tell one sentence and
Sure,
leave.
ma'am. Sure.
I think staff
Please go ahead.
is the most important thing in the institutional care, because taking these juvenile justice system or prison, they would have come to these institutions and nobody is there. So we are like family members to them, whether it is a doctor, nurse, or prison staff. So that is the most important thing. And the empathy and sympathy and the care what they need at that time, if you provide with little empathy, that is what is going to help them. It will help a long way in reformation and rehabilitation instead of a punitive center. So that actually is the most important thing. And we had actually trained a lot of prisoners. I'm sure Suresh, Naveen also were there during many of those sessions, and most of the work was done by the convict prisoners. So there was a big army of convict prisoners who were helping us. And to tell you, many of the prisoners who are working with the mental health team, they would remember, madam, this person is from Gulbarga jail. He had schizophrenia. We had put him on risperidone. So to that extent, they would remember. So the attitude of the staff and the co-prisoners, this is very, very important. Thank you all.
Thank you, ma'am. Thank you so much.
Also, just to, if I
yes,
can
sir.
add a couple of
Please add, sir.
to Rajni. Yeah, because most of the convicted prisoners, they're not hardened criminals. They, a lot of circumstances they're just normal human beings like you and me. So some other circumstances would have led them to commit that crime. So I think it's very important for us to differentiate when we say prisoners. Hardened criminals are different, rest of them are different, and most of them are they're normal human beings. In fact, entry into the prison increases the chance of them getting mental illness. As Rajni may also point out, the substance use prevalence was actually much less, and that had gone up significantly more after they entered prison. So these complexities also are there.
I think this is one day topic.
Now
tobacco use,
1 hour is
cigarette
not
and
sufficient.
BD use,
it
increased 4 times after coming into the prison.
Right.
Okay, there are other things also.
Yeah, and justice system, there are a lot of reforms that need to be done. And prison department is the most neglected among all the government departments. So we know how much importance is given. And in Western concepts, I think there is something called as a sentence planning. What should that sentence entail, and what is the rehabilitation plan after the convict goes out of the prison? So such systematic things are there. We are nowhere near
nowhere close.
Nowhere, not in the next 50 years, I would say. I would dare say.
And also during our study, the prisoners have mentioned, and we have also recorded in the book, they said the prison, the medical system is much better than outside, is what many of them have told. And 2 schizophrenics, many persons with schizophrenia, I still remember, after their release from the jail, they came back in the entry, and I was going out of, prison after my duty. 3-4 days they have come back. Madam, you please, give me medicine here only. I'm not able to go back. They're not accepting me. Exceptly one female I still remember. So that recidivism, that is very, very important. How do
Important.
so many women, they're not accepted back in the community or
Absolutely. Yeah.
And
So
especially severe mental disorder, men also. Their compliance and medication, everything was much better when they were inside the prison.
Yeah, it is unfortunate that there is no research. At least I have not come across any information on what happens to people after they go back after they serve their sentence, particularly those with mental illnesses. What happens to them? Only God knows.
But also, as Naveen told, we have to take many prisons and what is the service delivery during that time. The time when we did the study, full-time psychiatrist, I was there, and many prisons psychiatrists may not be there. This may not apply to those prisons. Patients coming back and asking us medicines. In that case, they would get better care outside. So it differs from setting to setting.
Center to center.
Yeah, center to center.
Thank you, ma'am.
Thank you all. I am logging off.
Thank you, ma'am. So any final comments from our speakers or panelists?
So I have one question to Dr. Preeti, ma'am.
Yes, Dr.
Ma'am, we just now heard a lot of discussion about what are some challenges they are actually facing once they are actually let out of the institutions, and they are not getting enough of support. So could you share some measures on how we can actually support for their long-term recovery and reintegration, and also to avoid subsequent relapse or even reinstitutionalization among the prisoners or even institutionalized persons with mental illness?
Yeah, so actually it is a fact that there's no planning for what will happen once they are released from whichever institution they are in.
Yes.
And this planning is very, very important. But I was just reflecting on what facilities do we have in Chandigarh and how can we provide if there is some need there. So if the prisoner is from Chandigarh and if he can access the services, then what all the services that we have in our department are available there. But if the person is not from Chandigarh, he's from some other city, and he has to go back to that city, then he will have to access the services which are available in his or her city. So that becomes the issue. But for the Snehala in Chandigarh, which is again coming to the institution for children in need of care and protection. So there we do support them, and there we have done some planning for them once they get out of this institute, along with the social worker and special educators and all that. Like how can they live independently in society? So
Thank you,
it's a long drawn pattern. That's what I would say.
Too many systemic related problems we still have, and
absolutely
planning phase. Thank you, ma'am. Thank you very much.
So any final comments or thoughts from our speakers or panelists?
I would like to state
Yes,
that
sir.
institutionalized persons is a very, very huge topic. Prison itself, as Rajni was mentioning, a lot of things to discuss. Likewise, juvenile justice homes,
That's a different
children
area
conflict
altogether.
law, that is a very big area. Elderly care homes. No, those are also kind of institutionalized persons only. They have their own issues. Elderly, we have not even spoken about it in this today's deliberations, because they have.
And ma'am also spoke about Nirashrita Kendra for the
Yes.
destitutes.
Actually, NPKs are there across the country, and even there, 50% of them, they do have either IDD or mental illness. In our Bangalore Nirashrita Parihara Kendra, about 1,000 inmates are there, out of which at least 400 of them, they either have severe mental illness or IDD. So, but actually they do come under Beggary Act. But mental health, they have mental health problems. So what are the provisions for them? And Swadhara Grihas are there for ladies. short stay homes are there.
Short
So
stay
I think
homes.
it's a very, very huge topic.
Huge
We are
topic.
able to just concentrate on prison because of the available constraints.
Yes. Thank you, sir. Thank you. So thank you. We indeed had a very fruitful session. So I'm sure all of us acknowledge that addressing the mental health of institutionalized individuals is a huge concern.
Prachit,
Not
I
just
just wanted to
yes,
know,
sir.
are we mapping these resources and as part of NMHS too? Is there any plan towards that? At least
Yes,
something in the
we
systems
do
assessment?
have it in the mental health systems assessment.
Okay,
So
okay.
we do have
Right.
a question, a variable on this.
Right,
Sir.
right. Thank you.
Yes, sir. Thank you, sir. Thank you. So, as we all know, it's a huge concern and they are extremely vulnerable. So, we need many comprehensive approaches which emphasizes on not just on early identification, but on continuous support, staff training, reduction of stigma. All these are extremely essential. And plus, we also need structural reforms. We've done considerable progress. A lot more needs to be done.
Prachit, sorry,
Yes,
one
sir.
more before I forget, if you're with your
Sure, please
I
feel free,
think
sir.
we should also start advertising Telemanas with all these
Telemanas.
institutions. Because at least some training we have imparted for
Yes.
networking to make services accessible. So if somehow if we are able
Yes,
to
sir.
catch these institutions and advertise Telemanas, that would also be of help in providing some assistance to those mentally ill who are residing in these institutions.
Very, very valid point, sir. Yes, sir. So, and even in our National Mental Health Survey, when we do the survey, we do give information about Telemanas, the number 14416 to everybody. So we've continued that, and of course, linking them up with Telemanas will do a lot of good. Thank you, sir, for that point.
Thank you.
So, yeah. So before we conclude, we'll have. I request all of you to please turn on your camera. We'll have a small selfie. I request one of our coordinators, either Dr. Akash or Mr. Sanu, to please take a selfie. So I'll take this opportunity to thank all of you, especially our resource persons, starting from Professor Naveen Kumar, Dr. Rajni, Dr. Preeti Arun, Dr. Malayappan, and Dr. Samrat, and all of you. At one point of time, we had nearly 100 people in this meeting, and now, of course, it's 70. But thank you all for your enthusiasm and interest. So we'll meet again after 2 months. And I would like to thank the entire coordinating team. Of course, Dr. Akash and Mr. Sanu were in the front. There were many others who worked behind the scenes. So thank you all for joining us for this insightful session. So we'll meet again after 2 months with another important mental health related topic under this mental health dialogue. Thank you all. Have a good time.
Bye-bye.
Thank you.
Thank you.
Bye.
Thank you so much. Bye-bye.
Thank you so much.